Okay, in part 2, we're going to cover the pharmacology. So we're going to go through some RSI medications. In the general sequence, just the medication sequence, not the full RSI sequence. This is just the pharm sequence. It's induction, paralytic, and then you provide post-intubation management with analgesia and sedation medications. Now, this will always be the sequence regardless of if you're doing RSI or DSI. The difference is that there might be a space here between the induction and the paralytic sequence. So the ideal induction agent would be one that does not cause hypotension, that does not cause respiratory depression, that allows the patient to breathe on their own, has no cardiotoxic effects, that improves cardiac output when you give it. Now, you might be thinking that that's ketamine. That's just not true. Ketamine can and will and does cause hypotension. It does cause respiratory depression. And sometimes it's dose dependent, but sometimes it is not, because ketamine requires endogenous catecholamines to maintain that tachycardia, that cardiac output. And if the patient has already exhausted their endogenous catecholamines, then ketamine can make that worse. Now, while it's not the perfect induction or sedative hypnotic medication, it's one of the best that we have. So the goal of administering ketamine or any induction agent, it'd be true if we used etomidate or Versed, which, Versed isn't great because it can cause hypotension more so than almost anything else would be given, is to ensure that patient becomes unconscious and that they won't remember the procedure. So if that was not a concern, then we would just push a paralytic, but it is not really ethical to paralyze someone and them still be aware of what is going on. The dose is, or the onset of ketamine is around 45 to 60 seconds. The duration, it lasts a good amount of time. So if you imagine you're given ketamine and then you want to pre-oxygenate a patient for around 3 minutes, and then you paralyze them, and then, let's say that whole sequence takes 4 or 5 minutes. You intubate them, you put them on a ventilator. You don't have to immediately rush to provide any post-intubation sedation. It should be first on your list to do once they're on the ventilator, but it's not anything that you have to think, okay, they're intubated now, we have to immediately administer ketamine. So the good thing about ketamine is that the patient can maintain their airway reflexes and breathing after ketamine, but that's not always the case. So it's a can. They can do that. It's not a guaranteed. However, conversely, ketamine can also cause laryngeal spasms, for which we perform Larson's maneuver. It can also make the patient have hypersalivation, which, isn't a major concern, especially if we lead with suction. They can have a rise in blood pressure, which is almost clinically relevant for the patients that we're going to be treating. Historically, it's taught that ketamine is contraindicated in patients with TBI for that reason. But that is no longer the consensus, because they've done studies where they've had patients undergoing surgery and they were measuring the intracranial pressure in the brain. They had a catheter in the brain or in the head, and they administered ketamine, and they did not see a rise in intracranial pressure. And I heard this from a surgeon as well. So he was fast to dispel any myths at some training we were having on giving ketamine to patients with traumatic brain injury. Now, of course, it is ideal for patients who have shock who have hypotension. Also for patients with asthma, bronchospasm, reactive airway disease, because it is a bronchodilator. It's not the best. That's why we don't just nebulize ketamine to everyone, but it does have those properties. So what is the dose? Well, generally, it's 2 mg per kg, IVIO for induction. Administer it slowly. If you push it rapidly, it can cause apnea. Remember, we want them still breathing, especially if we're performing delayed sequence intubation. And honestly, we want them breathing up until they become apneic, because that's when we want them to be able to maintain their SpO2 saturation up until that apneic point, which is the point in which we're going to remove the BVM from their face. Now, if their blood pressure is low or they're elderly, they might be particularly sensitive to ketamine, so we have the dose. We give 1 mg per kg to those patients. That's a very important point to remember. The opposite's true of paralytics. With paralytics, it's better to err on the side of caution as opposed to induction agents or sedatives. If they are hypovolemic, hypotensive, we do have the dose. Now, ketamine is dosed based on the ideal body weight, not actual body weight. All resuscitation medications it's recommended that you dose based on actual body weight, not ideal. Ketamine is different. There are formulas. We will have a cheat sheet on your checklist, on your RSI, DSI checklist. But this isn't hard to commit to memory. So the way you calculate ideal body weight is you estimate their height, and generally estimating their height is better than estimating their ideal body weight just empirically, and that's just my anecdotal experience. We're not good at estimating the body weight, but we're generally okay. We can look and see how tall someone is and compare that to our own height, and then subtract or add from there. So the rule of thumb is that for males, and our example here is a 5'10" person, and if it's 5'10" male, you start at 50 kg. So if they're 5 feet even, then their ideal body weight would be 50 kgs. Okay, so for every inch over 5 feet, you add 2.3 kg. So if this person is 10 inches over 5 feet, then 10 times 2.3 is 23. And then you add that to the base of 50 kgs at 5 feet, and then you get 73 kgs. For females, the math is the same, except with starting at 50 kgs. For 5 feet, you start at 45 kgs. Now remember, we calculate tidal volume based on ideal body weight as well. And what machine do we have that will calculate ideal body weight for us? Our ventilator. Yes, good job. So paralytics, what do they do? How do they work? So here's the too long didn't read version of this. And if you want to look more, if you want to research more into this, then you can. Here's to the acetylcholine at the postsynaptic receptors, and it hyperpolarize. Succinylcholine is a depolarizing agent, so it is continuously disrupting at that motor end plate, and that's why you get the fasciculations with acetylcholine. The other paralytics, such as rocuronium, vecuronium, they actually block the receptors at the motor end plate, so they are competitive, which is how we think of most medications that we give to reverse most reversal agents that we give. Most of them are competitive. Now, the main difference is that competitive paralytics, vecuronium, rocuronium, they last longer. They can last 30, 45, maybe even more minutes compared to succinylcholine. So here's a breakdown of kind of what this looks like. And this is the picture version of how succinylcholine, which is a depolarizing agent, works compared to those that are non-depolarizing. So succinylcholine has a very fast onset. For years, succinylcholine has been the go-to paralytic. Only recently has rocuronium and vecuronium, mostly rocuronium, gained popularity. And we could probably talk all day about the pros of succinylcholine versus the pros of rocuronium. And in the majority of head-to-head studies that you're going to look at comparing succinylcholine to rocuronium, it's pretty much a tie. There's no clear-cut winner on what's better. They both work just fine, but you have to understand each. The thing to understand about succinylcholine is the fasciculations, the list of contraindications, because there are many. The benefit of succinylcholine is that it has a short half-life, so the duration 6 to 10 minutes. So that is shorter than ketamine, okay? So that's a good thing. So that is a positive thing about succinylcholine. We don't necessarily have to worry about the paralytic, the duration of action of the paralytic being longer than the duration of action of our induction agent, because then we risk a patient being paralyzed and not sedated. That's also a negative thing about succinylcholine in a manner speaking, because if we require multiple intubation attempts at intubation to secure that airway, then eventually 6 to 10 minutes after the onset, that patient is going to lose that muscle paralysis, and succinylcholine could theoretically possibly have to be redosed. But it shouldn't in 99.99 something percent of cases. Now, the dosing is 1.5 milligrams per kilogram of actual body weight, not ideal body weight. And again, it is better to give a larger dose and err on the side of caution with a paralytic. It is much better for the patient to be fully paralyzed than not paralyzed enough. The thing is, though, the larger the dose, the longer the duration of action. Okay, the larger the dose, the longer the duration of action. Again, that's not necessarily a bad thing, especially if you have a difficult airway, you can't secure the tube, you paralyze them, you try to ventilate with a BVM, that's not successful, you try iGel, that's not successful. The rapidly desaturation, what do? Well, following the airway vortex paradigm, we would proceed with what? A surgical cricothyrotomy, and we would not want to do that with the patient waking up. Fortunately, the duration of action of ketamine is longer than the duration of action of succinylcholine. So there are some precautions and some contraindications to succinylcholine. Now, most of the contraindications we can rule out because we're usually not going to see those patients in that time frame. So if you look over here at burns greater than 5 days, okay, we shouldn't see anyone with massive burns that have had those more than 5 days that have not been to the hospital. Crush injury, if it's a large body, large muscle mass, so if it's like the thigh, or if it's multiple body parts that have been crushed, because again, succinylcholine does cause a small usually clinically irrelevant increase in the potassium, up to 0.5 MEQs per liter, which is a small increase. If they have a severe infection, I don't know what constitutes a severe infection, but if it's an extremely severe infection, a relatively absolute contraindication to the administration of succinylcholine is a history of malignant hyperthermia. That is a absolute contraindication, and neuromuscular disease. So if they have Guillain-Barré syndrome, ALS, multiple sclerosis, you want to be very careful to not administer succinylcholine. Now, in many of those situations, we might not know. So if you know, then obviously don't do it. But if you don't know and there's an adverse event, it frequently is manageable. So we're going to watch a quick video on malignant hyperthermia because it is a rare but very serious and consequential side effect of giving succinylcholine, or it can be.
A rare but potentially life-threatening condition called malignant hyperthermia. If you find this video interesting or helpful, I'd really appreciate it if you liked it and subscribe to the channel. Let's dive in. Malignant hyperthermia can be defined as a life-threatening hypermetabolic state characterized by dysregulated calcium, which, as you may know, plays a paramount role in muscle contraction. Who does malignant hyperthermia affect? It affects people who are both genetically susceptible and have received exposure to a triggering agent. And those include a depolarizing neuromuscular blocking drug called succinylcholine, as well as several anesthetic gases, including isoflurane, sevoflurane, and desflurane, and also halothane. However, halothane is not used very commonly in the United States, although it is currently used in a number of other places around the world, so depending on where you're practicing, this might be relevant. How frequent is it to be genetically susceptible to malignant hyperthermia? It's more prevalent in kids, with an estimated prevalence of 1 in 15,000 pediatric patients, and less prevalent in adults, with an estimated prevalence of 1 in 40,000 patients. It's really important to keep in mind that even if someone is genetically susceptible to malignant hyperthermia, that does not necessarily mean that exposure to a triggering agent is going to cause an episode of malignant hyperthermia. And that brings me to my next point, which is how often an anesthesiologist might actually expect to see malignant hyperthermia. A study that was published about 10 years ago found that there were 84 identified and reported events of malignant hyperthermia that occurred over a 5-year period. And out of those 84 events, 8 of those patients died. That means that over the study period, about 1.6 people died in the United States every year from an episode of malignant hyperthermia. By way of comparison, every year in the United States, an average of 62 people are killed from a lightning strike. That means that on average, in a given year in the United States, a person is about 39 times more likely to die from a lightning strike than they are from an episode of malignant hyperthermia. And the really important qualifier for that is that if an anesthesiologist is prepared, then identifying and treating malignant hyperthermia can be life-saving. How do you treat a patient who you think may have malignant hyperthermia? Well, first it's important to understand what exactly is going on when an episode of malignant hyperthermia occurs. If someone who's genetically susceptible is exposed to a triggering agent, it may cause an uncontrolled release of calcium in cells basically throughout the body. This uncontrolled calcium release occurs in muscles throughout the body, causing them to contract, which is a process that uses a lot of energy, a lot of oxygen, and produces a lot of carbon dioxide, or CO2. There are a number of significant complications that can arise from an episode of malignant hyperthermia, and one that can manifest immediately and be life-threatening is hyperkalemia, which is elevated potassium levels throughout the body, which can occur because potassium regulation is also thrown off during an episode of malignant hyperthermia. This, in and of itself, can lead to a fatal cardiac arrest. Just as an aside, for anyone thinking about a career in anesthesiology, it's worth pointing out that we are experts in resuscitation, including advanced cardiac life support. So if there's a cardiac arrest or any other type of life-threatening event that occurs in or near an operating room, then we are very well equipped to handle that. Other potential complications of malignant hyperthermia include a condition called disseminated intravascular coagulation, which in and of itself can be fatal, as well as organ failure of basically any organ, especially including the brain as well as the kidneys. Studies show that the mortality rate associated with an episode of malignant hyperthermia ranges from 5% to 30%, where faster time to treatment is going to lead to improved survival. So how do you take care of a patient who may have malignant hyperthermia and be susceptible to having an event during your anesthetic? The first consideration is to make your patient the first patient of the day. Reason being that studies have demonstrated that overnight, the triggering agents that are present inside of anesthesia machines actually degrade when the machine is not in use. So you don't want to be using a triggering agent like isoflurane or sevoflurane throughout the course of the day and then take care of a patient using that same machine, which may have some lingering molecules of a triggering agent inside of it. Then as far as the machine itself is concerned, you actually want to remove every replaceable part that could potentially have come into contact with a triggering agent. That includes the entire breathing circuit, the absorbent, and if it's possible to remove the vaporizers from the machine, then you should go ahead and take those off. If it's not possible to remove the vaporizers, then at the very least, cover them in red tape so it's abundantly clear that they shouldn't be used. Then, if you have charcoal filters available, go ahead and place those on your circuit and flush the circuit and the anesthesia machine for a certain period of time, depending on whether you have filters on and what type of anesthesia machine you're using. I should point out that if you're not able to use charcoal filters, then it's really important to keep your gas flows high throughout the course of the anesthetic, because it's possible for triggering agents to reaccumulate if the flows aren't high enough. A big challenge for anesthesiologists is that an episode of malignant hyperthermia isn't always very easy to identify, but if you think that your patient may be having an episode, it's extraordinarily important to initiate treatment as early as possible. Due to the muscle contractions that happen throughout the body during an episode of malignant hyperthermia, one of the signs that may tip you off that your patient's having an episode is muscle rigidity throughout the body, and especially in the masseter muscles of the face. Keep in mind that muscle rigidity doesn't always happen during malignant hyperthermia, and also keep in mind that other conditions like neuroleptic malignant syndrome can also cause muscle rigidity. So this in and of itself isn't going to be the single diagnostic indicator that a patient's actually having an episode. Another really important sign that your patient may be having an episode of malignant hyperthermia is hypercarbia, which means increased levels of CO2. Monitoring a patient's exhaled CO2 is one of the American Society of Anesthesiologists standards of care. So we're always watching a patient's end tidal CO2, which means what they're breathing off. And so if that end tidal CO2 is rising, and especially if a patient is intubated and we try to breathe off that CO2 by either increasing the respiratory rate and or increasing the tidal volumes, but the CO2 is not going down, then we have another indicator that the patient may be having an episode of malignant hyperthermia. Other less specific signs of malignant hyperthermia, meaning ones that can be present in a number of different conditions, include tachycardia, or an increased heart rate, as well as an increased temperature, hence the name malignant hyperthermia. Keep in mind that monitoring temperature is part of the American Society for Anesthesiologists standards for basic anesthetic monitoring. Overall, making an intraoperative diagnosis of malignant hyperthermia can be pretty hard to do, but you have a higher likelihood of making correct diagnosis if there are at least two signs that are present. As far as timing goes, the majority of episodes of malignant hyperthermia occur in the operating room during the delivery of anesthesia, and only a small proportion of them occur after anesthesia has finished in the post-anesthesia care unit. If you're delivering anesthesia and you suspect that a patient is undergoing an episode of malignant hyperthermia, then the very first thing that you need to do is discontinue whatever triggering agents are currently being administered. That might include isoflurane or sevoflurane. It's pretty unlikely that you have a succinylcholine infusion going, but if you do, then you should stop that. If the surgery needs to continue, but you've just turned off an inhaled anesthetic maintenance agent, then you'll need to switch over to a total IV anesthesia, or TIVA for short. This commonly includes propofol, which is not a triggering agent for malignant hyperthermia. The next extremely time-sensitive intervention that needs to occur is the administration of the treatment, which is dantrolene. Dantrolene is a medication that blocks calcium release from muscles and thereby inhibits the pathophysiology of what's going on during an episode of malignant hyperthermia. A patient's survival of an episode of malignant hyperthermia is directly related to the amount of time that it takes for dantrolene to be administered. For those who are interested, the dose of dantrolene is 2.5 milligrams per kilogram administered every 5 minutes, and it's important to monitor a patient's vital signs for resolution of symptoms. And also keep in mind that treatment with dantrolene may need to continue even after symptoms have resolved because it's possible for them to reoccur. Dantrolene is an extremely expensive medication, and for that reason, it's not routinely kept in carts in every single operating room, but rather in its own cart that's located centrally to all of the operating rooms. I've covered medication cost in one of my previous videos, and I will say that became a very controversial subject, but I will just say that objectively speaking, the wholesale cost, so what a hospital pays in the United States on average for a vial of dantrolene is $2,581 for 250 milligrams. That's the cost for a formulation of dantrolene that can be reconstituted into 5 cc's of sterile water and then injected. That contrasts with the other formulation of intravenous dantrolene, which comes as 20 milligram vials that cost $62 each, but each vial needs to be mixed with 60 cc's of sterile water. From a practical standpoint, this formulation of dantrolene is actually really tedious to use because it takes a long time to draw up enough dantrolene to administer to a patient who's having an episode of malignant hyperthermia. One also cannot talk about dantrolene without mentioning that calcium channel blockers are contraindicated because the use of calcium channel blockers with dantrolene can precipitate a life-threatening hyperkalemic arrest. Also kept in the cart is refrigerated IV fluid, and in this case, that's Isolite. The administration of cold IV fluids is one of the most effective ways to rapidly cool a patient. Another medication kept in the malignant hyperthermia cart is a medication called bicarbonate, which can decrease the acidity of urine, thereby decreasing the likelihood of kidney damage resulting from myoglobin, which came from ruptured muscle cells. To that end, a diuretic called furosemide is also recommended for treatment during a malignant hyperthermia episode because that can increase urine output and theoretically decrease the amount of renal damage. The malignant hyperthermia cart also includes insulin, which drives potassium inside of cells, decreasing the likelihood of life-threatening hyperkalemia. And if you're going to be administering insulin, then in order to keep the patient's blood sugar from bottoming out, you'll also probably need to administer dextrose, which is kept in the cart as well. The recommended ventilator settings for treating a patient with a suspected episode of malignant hyperthermia is 100% FiO2 at high flows and hyperventilating the patient to try to get the carbon dioxide off as much as possible. Other important steps for treating malignant hyperthermia include making sure that a patient's urine is being closely monitored, so a Foley catheter will need to be inserted if it's not already inserted, and the patient will need to be very closely monitored in the ICU after leaving the operating room. And if there's any question about how to treat a patient with a suspected episode of malignant hyperthermia, there's actually a hotline that's staffed 24/7 by experts who can guide you through any questions that you may have. There are several ways that susceptibility to malignant hyperthermia can be diagnosed. One is a fairly invasive diagnostic test that is not done in very many places in the United States and also happens to be really expensive, and that's called a caffeine halothane contracture test. That basically entails.
Okay, so we have covered the major signs and symptoms that you want to be aware of with suspected malignant hyperthermia and the management of malignant hyperthermia. So let's move on. You can get laryngospasms occasionally, either after the administration of succinylcholine. The SUX abbreviation is not appropriate. It should be SCH, but SCH is a good abbreviation for succinylcholine. But this can also occur after the administration of ketamine.
Laryngospasm, a common complication after extubation, can be treated by the Larsen maneuver. To perform the maneuver, first locate the laryngospasm notch behind the lobule of the pinna of each ear, anterior to the mastoid process of the temporal bone, and posterior to the ascending ramus of the mandible. Press the middle finger firmly on the notch in a cephalid direction. Some degree of jaw thrust may also be applied.
So you can perform Larsen's maneuver as you're using your two-hand seal, as you've got the mask on the face, and you are pulling that chin into the mask. If you do a jaw thrust and you push at that notch, then you can help relieve laryngospasm. So other paralytics that could be used in the future that you might see used in the hospital is rocuronium. This is, the onset is generally a minute, and in cases where rocuronium is used for RSI, now this is postulated, if the intubation success rate is higher with succinylcholine, a lot of people theorize that it's because you don't wait long enough before you attempt intubation. You don't wait until there's full muscle paralysis. Now, the key, the hallmark thing about rocuronium is that the duration is long. It can last anywhere from 30 to 60 minutes, which some say is a good thing, because if the patient's undergoing RSI in the ER or in EMS, in the pre-hospital field, you have no choice but to proceed with securing that airway. You're not performing the procedure of intubation because the patient's undergoing a routine appendectomy or something. You're doing it because you have to get that airway secured. Now, I did not mention, but now is a good time, succinylcholine does require refrigeration, but it is good for up to 2 weeks after it's removed. It's got a pretty wide temperature range for it to be refrigerated at, so it is not it's not a major concern, but it should be refrigerated, and it will not lose its potency for up to 2 weeks after you remove it from the refrigerator. This is the preferred paralytic when succinylcholine is contraindicated, but after many discussions on this with our medical director, and based on his experience using succinylcholine in the ED, practically speaking, the contraindications to succinylcholine that you're going to see are pretty rare. And there are no known contraindications to rocuronium except for a patient that does not need rocuronium. We do not give succinylcholine for continued paralysis. It is not ideal to have to repeat succinylcholine. You can if you must, but it's not ideal. And once you secure that airway, continued paralysis is very rarely indicated, so we did not include that in our protocol. Ketamine is used as our post-intubation sedative and analgesic. Now, you can use other things as an analgesic. You can use fentanyl, but it is important to note that you will not want to administer Versed in isolation for post-intubation management, because it does not have any analgesic properties. It only has sedative, anxiolysis properties. Now, if you choose to give ketamine, which is what we're probably going to do most of the time, it provides analgesic and sedative properties. There may be times where, we're going to use ketamine for induction, but you're thinking this patient has a TBI, their blood pressure is through the roof. I might want to bring that down a little bit, so I'm going to give fentanyl and midazolam or Versed. Fentanyl has a fast onset of action. I think fentanyl's a great drug. And, if you're giving ketamine and maybe the blood pressure's low, but you want to kind of blunt that sympathetic response, you can give fentanyl in addition to administering the ketamine. You don't have to just give ketamine alone. But we generally wouldn't administer ketamine, fentanyl, and Versed unless you're given Versed because the patient is having an adverse reaction to the ketamine. So they're in the no man's land between the analgesic dosing and the dissociative dosing. For sedation, again, ketamine can work both ways, or you can give Versed for post-intubation, but not alone and not for induction. It has a pretty long duration of action. Versed's a great drug. It's a great choice for post-intubation sedation when needed.